I'd like to welcome everyone today to the Vasculitis Foundation webinar. I'm Kathy Olevsky, the host for the Vasculitis Foundation's educational webinar series, and I'm also a patient living with MPA vasculitis. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. Today's webinar is Understanding Your Labs with Dr. Rula Haj-Ali. And after we finish this webinar today, there will be a recorded version on the Vasculitis Foundation's YouTube channel so that everyone who's registered today will receive an email with a link to it as soon as it's available. That way you can share it with any friends that might have missed it today. And before we get started, just let me go over a few details. Again, this is a live webinar, so we have muted everyone except our guest speaker. In today's webinar, Dr. Haj-Ali will do a presentation about labs, and after her presentation, you all will have the opportunity to ask her questions. These questions can be asked by typing your questions into the Q&A box. Since you're muted, we will need you to enter them through the Q&A box. If you don't see it, just click on the three dots to the far right bottom of your screen where it says More. Please make sure your question is a general question about today's topic because Dr. Haj-Ali is not your doctor and she cannot comment on your specific medical situation. So there's also a chat box, and if you'd like to chat with others that are watching today, you can do that, but that's not the right place for the questions. So look for the Q&A box after the presentation for your questions. And now that everything is pretty much covered, I'd love to introduce our guest today. Dr. Rula Haj-Ali is a professor of medicine and staff physician at the Center for Vasculitis Care and Research at the Department of Rheumatic and Immunological Disease, and she's the associate director of the Vasculitis Center at the Cleveland Clinic. She's also the vice chair for quality and safety for the Medical Subspecialty Institute, and she is board certified in internal medicine and rheumatology. So welcome, Dr. Haj-Ali. We are so happy to have you with us today, and I would love it if you would share any disclosures you have before you get started.
Thank you so much, Kathy, for inviting me, and thank you, the Vasculitis Foundation, for hosting such amazing webinars over the years. I do have some disclosures, which I'm a consultant for Amgen, and I also get royalty from UpToDate, which is a forum where we can write chapters about different diseases. And also I am consultant for JSK.
Well, thank you for that. And anytime you're ready, we're anxious to hear more.
All right. Good afternoon, everyone. Thank you all for joining. I'm trying to put in some slides to go over the basic things. You know, what is the understanding behind these labs that we order for you? And what I also want you to get from this presentation is help your doctor monitoring this lab with you so that you can understand in a deep dive into what's going on for most of the tests what we were going to share. All right. It's not advancing. Here we go. So vasculitis is, as you know, affects vessels in various size and type and location, leading to various clinical presentation. So different vasculitis do have different blood test abnormality, and some tests can be abnormal in all vasculitis. So not everything is the same, and you have the same blood test abnormality. And you've seen this over and over, and I put it again because this is kind of like the whole diagram of vasculitis, different type of vasculitis. We have the large vessel, we have kind of the medium and the small vessel vasculitis. And every type of vasculitis has different abnormal blood tests. When I say Takayasu and giant sand arteritis, in this type of vasculitis, the ANCA is negative, so you're not going to have an ANCA positive here. In the medium vessel vasculitis, such as polyarteritis nodosa or Kawasaki disease, also your ANCA is negative. And the ANCA-associated vasculitis, such as GPA, EGPA, MPA, these are the type of vasculitis that have ANCA. So ANCA by itself does not rule out all vasculitis because there's different type of vasculitis. But we're going to talk about, the most common also blood tests that you see daily other than the ANCA. And there is different type of immune complex vasculitis, such as a cryoglobulinemic vasculitis, IgA vasculitis, and hypocomplementemic and anti-GBA. All right, so most of the tests that your doctors are going to look for initially when you feel sick upon the diagnosis or the initial presentation is this kind of list. Complete blood count, which we call it CBC, complete metabolic profile, which we call it CMP, cryoglobulin. This is a test for a specific type of vasculitis. We also look for other things, such as anti-nuclear antibodies. And this is a test for lupus and condition that looks like lupus. Rheumatoid factor for rheumatoid arthritis. This can also be positive sometimes in vasculitis. We also look for other things that can look like vasculitis, such as hepatitis C and B. Always test for TB testing, tuberculosis, because the medication we would use, we want to make sure that you have not been exposed to tuberculosis or even hepatitis. And then the ANCA testing and urine analysis. These are the most common tests that we initially use when we suspect somebody have vasculitis. And also some of them are also used for monitoring blood tests. And I'm going to go over them. So let's see the CBC. This is the component of the CBC. So CBC, you have the white BC, which is the white blood count, the red blood count, which is the red blood cells, which is the amount of cells, which are red cells, which are responsible for hemoglobin and hematocrit, which is if you are anemic, your hemoglobin goes down, your hematocrit goes down. Your platelet count is good for coagulation and maintaining the, that you don't get any bleeding. These part of the white of the CBC, the MCV, MCH, MPV, all these up to here. This mainly reflect the size of the blood cells, and the shape of the blood cells. These can be affected with genetic diseases such as things like thalassemia. If somebody have iron deficiency anemia, like they're deficient in iron, the mean volume of the cells becomes smaller, and this becomes very small. Or if somebody have deficiency of some vitamins and they have anemia, we can, from these, the way the shape of the cells can give us some idea of the type of anemia. So that's kind of like where what these are. And then after that, you actually look at white blood cell differential, which is this part here, which is how many of each of the different type of cells you have, how many you have neutrophils, how many you have lymphocyte, monocyte, eosinophils, basophils. These are the type of the white blood cells. And these are important also to look at in most infection or acute stress to our body, whether it is infection or inflammation from vasculitis or even trauma, any like acute stress, we will have a high white count, we will have a high neutrophils. But folks who have eosinophilic granulomatosis with polyangiitis, they know that also eosinophils are high in this condition, and that can reflect type of allergies, the amount of allergy that we have, and reflect sometimes reflect the activity of the disease. So this is the component of the CBC when what it means. In vasculitis, in general, white blood cell count can be elevated at the diagnosis. If someone come in with different symptoms that look like vasculitis, but then the white count is actually on the low side, we should think about something else other than vasculitis. And if we have elevated white blood cells, can occur with other medications such as glucocorticoids. So I get a lot of question on, oh, why this is after treatment, why my white count is elevated. That can be elevated from the prednisone. This is expected. And this is artificially elevated. So the prednisone, the steroid, moves the white count from the bone marrow to the blood. They just move them. And then when you measure them in the blood, they look high. The differential is, as I said, how many of each type of the white blood cells you have. And there's, as I said, eosinophils is usually elevated in EGPA. So this is really important. Neutrophil can be elevated at the diagnosis and with glucocorticoids. Hemoglobin and hematocrit and the red blood count can be low, and vasculitis can cause anemia, and this is what we look for as well. And platelets usually elevated at the diagnosis, and again, low platelet is unusual at the diagnosis of vasculitis. So if you have low platelet, you have low white count and symptoms that look like vasculitis, we usually look for something else. So as I said, elevated white count, what happened to the white count with the treatment? We expect to have a high white count with glucocorticoids, such as prednisone. Low white count can occur later on with medications, such as cyclophosphamide, rituximab, not much as in rituximab, but it can happen. Other medications, such as azathioprine, mycophenolate, and methotrexate. Especially with cyclophosphamide, we monitor the CBC very closely. If someone is on cyclophosphamide, we really need to have a CBC every week. And this is really not fun to do, but it is important for us so that we can adjust the dose. Hemoglobin, hematocrit, and red blood cell usually improve with treatment, but also may be affected with medication. But not as much as the white count, and the platelet count improve with treatment, so it becomes lower and rarely affected with medications. All right, it's a big component of what we really want to monitor. So, and even upon diagnosis, we always look for inflammatory markers. So let me step back a little bit and tell you what are the inflammatory markers. So in acute inflammation, if something happened to us now acutely, whether we are sick with COVID infection, whether we cut, like our skin, or we have autoimmune disease, there is changes in the concentration of a number of plasma protein. They're called acute phase reactant. And this is, just go up as a defense for widespread inflammation. So the body senses there is something happening in the body, and I really need to defend that. And this protein goes up, and this is called acute phase reactant. And this is related to cytokines, which are also proteins such as interleukin-6, that is mainly secreted in the liver and then acts on the blood cells to start to increase all these acute phase reactant. And there are acute phase reactant that goes up, and there are some that goes down during inflammation. So that's what we say positive acute phase reactant, which is the one that goes up, such as C-reactive protein that we measure a lot in our patients to look for inflammation and to see if they're doing well on the treatment, as well as the sedimentation rate, which is called erythrocyte sedimentation rate. It's the rate by which of how much the erythrocyte, which is the red blood cell, settle down. I'll show you some picture to explain it. And there are some other acute phase reactant, fibrinogen, alpha-1 antitrypsin, haptoglobulin, procalcitonin, serum amyloid, ferritin. So we don't do much of those. Most what we do is ESR and CRP, but there are other also I lost my slides. Here we go. There are others, autoimmune disease, where we focus on some of these. And there is a negative APR, meaning that during acute inflammation, we will see these protein goes down, such as albumin will go down, transferrin will go down. So there are different things that happens in inflammation because of the acute phase reactant. So let's see what is ESR. So everybody focus on the ESR. At the beginning, we want to make sure we look for inflammation. We look inflammation during different part of the body. We also look for it in the blood. And that help us to see there is inflammation going on or not because of the symptoms upon diagnosis when they come in. And also it's important for monitoring, how we do after treatment. And even when we stop treatment, we look for these markers as reflection if there is any inflammation going on in the body, even before our patients, feel anything. Many of you are not on the treatment, but they're into the phase that are off treatment, but they are being monitored. And this is one of the tests that we also monitor. So what is ESR? So it is erythrocyte sedimentation rate. So it is defined as the rate expressed in millimeter per hour at which the red blood cells suspended in the plasma settle down when placed in a vertical tube. So you take your blood, they take your blood and they put it in a tube and they measure the time, how long it takes for these RBCs to settle down in the vertical tube. And they measure it here, millimeter per hour. So in an hour, how much is that? And this is an indirect measure of a protein, mainly fibrinogen. If you have a lot of fibrinogen in the blood, the RBCs will become a rouleau, kind of like stick together, and they settle down quickly. And this is when you have a high fibrinogen in the blood. So elevated sedimentation rate is a reflection of how much fibrinogen is in the blood, which is an acute phase reactant, which is high in inflammation. But increased sedimentation rate, and this is something that you always ask your patient, your doctor. Sometimes you feel great, and your sedimentation rate maybe has not gotten better, or has always has become high and never went down. Although your CRP, which is another inflammatory markers, is normal, but your sedimentation rate is abnormal, and that because there are so many other constituent in the blood that can affect the sedimentation rate. If you have other protein, there's some protein in the blood, they're called monoclonal protein. So our body is very, very smart. So when they see there is a lot of inflammation, they try to fight this. They try to build up antibodies. So these antibodies, they're called proteins, and they can be high in the blood. And if they remain high for a long time, and that will raise the SED rate, although there is no inflammation, but the protein is high in the blood and can raise the sedimentation. If you have anemia and changes in the red blood cell size, shape, and number, your sedimentation is high. Technical factors, different labs. Some people, do it in a different way. So that's why sometimes we repeat the SED rate if it was not given in the same lab. And it's always important to have your lab tested in the same lab so that, will be continuity of, trying to compare apples to apples. Just by age, when we get older, our SED rate increase. Female usually tend to have a higher SED rate than male, even at the normal age, at the same age with the normal health status. As I said, anemia, pregnancy increase the SED rate, malignancy, obesity, of course, infection, and tissue injury. So you see, there is a high list of things that can increase the SED rate. So most of the time, when we are dealing with vasculitis and we see high citrate and somebody, their citrate has been normal, and then you suddenly have a high citrate, the first thing that comes in my mind is there is an infection. I call my patient, making sure there is no infection, and at the same time, there is no flare. But this is part of this because infection can increase a high citrate. So when you see these labs, even vaccines. So sorry, I didn't put that in. So now most of you are being vaccinated and you do your labs, and your labs come back a high citrate or a high CRP. I just had a patient of mine saying that I feel fine. What's going on? Is it my vaccine? And I said, yes, it is your vaccine, because your vaccine is a stress for your body and it's going to increase your citrate. So don't panic for that. CRP is another acute phase reactant and influence multiple stages of inflammation. It goes up with inflammation, and it can have a little bit some anti-inflammatory also action. But CRP promote the recognition and elimination of pathogen and enhance the clearance of dead cells. So this is really important when we have something and the body try to defend itself. So it does start secreting CRP. So the different type of CRPs, there is the standard CRP, and it's reported as by milligram per deciliter, or there is the high sensitivity CRP, which is reported per milligram per liter. This is what the cardiologists use most of the time, high sensitivity CRP. In inflammation, we use the regular CRP. The way to differentiate between both, look at the unit. The standard is milligram per deciliter, and this one is milligram per liter. This high sensitive is really, really sensitive. Like if you cough up a little bit in the morning, your CRP is going to be high sensitivity, is going to be very high. So sometimes it can be very concerning for our patients to see these little changes in the high sensitivity CRP. So we tend up to do mainly the standard CRP. And if you look at the population, there is not real normal CRP. There is a range of CRP. And there was a survey that was done by NIH when look at 21,000 people, and then revealed that CRP level vary with age, sex, and race, and slightly higher seen with increased age, female sex, and people identifying as African American. So there is a lot of factors. In heart disease, it is a increase. And I'm going to show you another list of things that can increase CRP. And also, you have, when you have hardening of the blood vessel, like atherosclerosis, if you have hypertension, if you have heart disease, if you have obesity, sleep apnea, what we call metabolic syndrome, which is a little bit of diabetes, high blood pressure, a little bit of obesity, we call it as insulin resistance, that can increase your CRP. And that's what the cardiologists are looking at when you go and do your cholesterol. They always do high sensitivity CRP to see if these, high blood pressure, high cholesterol are really affecting your body in inflammation. And they target the CRP to be lower. Poor diet can also increase the CRP. So these are two tests for the most common tests that we use for inflammation, and that is across all the different vasculitides that we have. Most of these we do CBC, we do citrate, we do CRP, and upon diagnosis it's high, and later on it goes down. But take into consideration the other things. Very, very important test that we always do is a urine test. Don't skip that. Sometimes we skip that in the lab, but that's important. And I'll tell you why it is important, especially with people who have had kidney disease, like the ANCA Associated Vasculitis, like GPA, MPA, EGPA. These are conditions that affects the kidney. And one way to really look if there is any flare in the kidney, because flare in the kidney does not cause any pain or doesn't cause any other features, except that it starts with abnormal urine test. So you will start having abnormal protein. The protein will be high. and the blood in the urine will be high. These are two things I tell my patient, always look at in the urine test, whether you have a blood in the urine or protein in the urine. But keep in mind that some people who have had kidney disease, they always have protein in the urine, and they will never clear that. Although there are medication now that protect the kidney, and they should talk to their physicians about having some medication to decrease the amount of protein in the urine. But let's say, there is some amount of protein that's always there. Always look at the change of the protein in the urine. But very important also is the blood. When we have a flare in the kidneys, the blood goes up, the protein goes up, but then over time this gets better, and most of the time the blood in the urine, which is called the hemoglobin, goes away. And when we see there is more blood in the urine coming back, we have to be careful that this may be a flare. Other component of the urine test that I really look for, unfortunately, the lab doesn't tell our patient to have a clean catch urine. So most of the time we'll see white cells or bacteria. And I get a lot of question about that. Epithelial cells are just cells around the area that are normal, and it shouldn't have any issues if you have epithelial cells. Even if you have bacteria and you don't have symptoms, it shouldn't be an issue. But if you have symptoms, you should get a urine culture. Hyaline cast does not mean RBC cast. This is also some kind of different debris that come in with the urine. So most of the time in the clinic, we do get the dipsticks. We ask you to get a urine, and we dip it here in the clinic, and we look at protein and urine. And if we see there is something abnormal, we take a sample and we look under the microscope for this features. Is called RBC cast. These are red blood cells, RBC, red blood cells, lined up, meaning these red blood cells came from the kidney with a lining around it and went down to the urine. That is a reflection that there is something going on up in the kidney. And, that could be just a flare, symptom of a flare. So this is not done in the lab. Very rarely the lab technician can recognize an RBC cast. Hyaline cast is not RBC cast, but I would say always look for hemoglobin and a protein. Oops. All right, let's look at the complete metabolic profile. And in that, what we have sodium, potassium, chloride, CO2, which are all the electrolytes. Then you have your BUN, creatinine, glucose, protein, calcium, phosphorus, albumin, bilirubin. And then you have your alkaline phosphatase, AST, ALT. So these three are the liver function tests. Your kidney function test is your creatinine and the eGFR, which is the estimated glomerular filtration rate. It's estimate. So it takes your creatinine in the blood and also your age, and it estimates how much your kidney is functioning. Anything above 60% is normal. But it's also an estimate. But you have to put these together. So in that, we look at the creatinine mainly, we look at the GFR, we look at the liver function test, we look at the glucose. If someone's taking high dose prednisone, we look if their sugar is elevated. We also look for other things such as potassium can be low in patients who have been on a high dose of steroid, glucocorticoid, and prednisone. And that's something that important to also look into at diagnosis to see if there's kidney involvement or not. Upon some people who have vasculitis initially at the diagnosis, their liver function test can be elevated as well, and it gets better with treatment. I want to say something. I forgot. I'll get to it. So that's the CMP is also monitored, later on during your monitoring lab. Yes, I remember what I want to say. Your creatinine is a reflection of the kidney function test. But this one, when it start going up, the first sign is not just the creatinine, is actually your urine test. So if you catch the blood in the urine here and the protein, you may be catching a flare in the kidney before even your kidney function tests have been affected. So that's why I put really weight on and importance on the urine test. So please do your urine test. All right, so let's talk about the ANCA test. So ANCA test is positive in these different type of vasculitis that we call them ANCA Associated Vasculitis. We abbreviate it as AAV. These are primary systemic vasculitis characterized by vasculitis of the small and medium vessels, and they are associated with a positive ANCA test in the blood in majority of the cases. And they share together some other features like kidney involvement, neurologic involvement, but each one has different symptoms. Like the EGPA, eosinophilic granulomatosis with polyangiitis. It happens in about 11 to 14 per million. Granulomatosis with polyangiitis, GPA, in about 2.3 to 146 per million, and microscopic with polyangiitis as MPA. And there is also renal limited ANCA vasculitis. That's the only vasculitis is in the kidney. And most of the time people are diagnosed not because they have symptoms. Remember, kidney disease doesn't have symptoms until it is really late stage. But in the early stage, people get in to have a blood test, routine blood test for some reason, and they found to have this. So these are the type of vasculitis that has a positive ANCA. Let's talk about the ANCA test. So ANCA test is being, when I order ANCA tests, I get 4 different type of results. They look at the fluorescence. How do we do for ANCA? Let me move to the second. So these are the cells. Okay, and then they mix them with antibody to the ANCA, and they look under the microscope. And this is what we call fluorescent, immunofluorescent. If someone works in the lab, understand what I'm talking about. And if it is cytoplasmic, meaning around the cytoplasm, we call it c-ANCA. If it is perinuclear, around the nucleus, we call it p-ANCA, perinuclear. So this is the fluorescent type of the test. And then also they look specifically for other antibodies such as PR3 and MPO. There's so much other antibodies, but mainly what we look is for PR3 and MPO. And a positive ANCA test can be positive only c-ANCA, only p-ANCA, or you can have c-ANCA with any of these two, or p-ANCA with any of these two. If you have a c-ANCA positive and a PR3 positive, it becomes more specific. We are more reassured that this is the right diagnosis, what we're doing, even just looking at the ANCA by itself. But if you start having discordance where you have everything is positive, and you also have the test for ANA positive, which is the test for lupus or rheumatoid factor, and so many other tests are positive, you start asking yourself, what's going on there? Why do I have all these tests positive? And that could be because some drugs, there are medications that can cause vasculitis, such as hydralazine or very, very rarely minocycline. And this by itself can cause ANCA-associated vasculitis, and you will have a positive serology everywhere. So the type of positive test also tells us, sometime what is the diagnosis. But ANCA can be also positive in non-vasculitis syndrome, like lupus, in the lupus spectrum, like Sjogren can be positive in ulcerative colitis. It can be positive in autoimmune hepatitis. If you have a positive ANA in lupus or other autoimmune disease, the ANCA can be positive. In patients who have cystic fibrosis, in patients who have endocarditis and infection, and we talked about the drug-induced, and even in patients with cocaine use, they can have vasculitis and positive ANCA. So ANCA by itself is positive in these ANCA-associated vasculitis. Negative ANCA doesn't rule out vasculitis because there's so many other vasculitis syndromes that does not have a positive ANCA. And a positive ANCA itself doesn't mean that the patient have ANCA-associated vasculitis. We really need to look for everything else. Okay, I'm going to go to the rarest type of vasculitis. This is an IgA vasculitis where this protein called IgA, immunoglobulin A, starts precipitating in the blood vessel, and it causes vasculitis, mainly in the skin, but sometimes it affects the kidney and the intestine. It's more common in young, but we see it also in adult. And when you look at the tissue and you stain for IgA, it is positive, and sometimes in the blood, you will have IgA abnormality, which is high. A little bit about cryoglobulinemic vasculitis. This is a very rare type of vasculitis that is mainly affect the skin. It also can affect the gastrointestinal tract. It affects the heart, the brain, and the nerves, and the skin. Very rare, is 10 cases per million worldwide. And what happens here is that there is an abnormal blood protein called cryoglobulin. It clumps together. It comes together and clumps together at cold temperature. And then it does, you have this clump inside the blood vessels that causing damage to, and the flow doesn't go. So you are restricting the flow to all the organs where you start having damage in the organs. And you can have it in the skin, the muscle, the nerves, and the kidney. And this can be positive. We see that mainly in patients who have hepatitis C. Remember when the first thing I put in that we also screen for hepatitis C in our patients with vasculitis, because cryoglobulinic vasculitis happen because of the hepatitis C infection. That's the most common, but we can see it in other conditions as well, but that is the most common. But this cryoglobulin test, it is very sensitive how we do it. And sometimes we send patients to labs that they don't do that very often, so it can be done in inaccurately. And let me give you a little bit background about that. So with the proper way to do a cryoglobulin test is that you take 10 to 20 ml of blood, and it has to be put in a pre-warmed tube without anticoagulants. Remember, cryoglobulin, they clump together during cold. So if your tube is not pre-warmed, they're going to clump together, and then you're going to you take the supernatant, the upper part, and then you look for cryoglobulin, and you can't find them because they're clumped, because it is inappropriately collected. And sometimes if you have things that we keep in the blood tube, we call them anticoagulant, can also cause high cryoglobulin. So if you want to do a cryoglobulin test, make sure you do it in a lab that knows what they do. And this is why sometimes your physicians is asking you to do this test in a big centers where they know what to do. All right, I am going to stop here. And I talked a lot. I'm sure I missed a lot of things. So I'm so happy to take any questions.
Well, thank you so much. Honestly, I am writing notes furiously. So you may have missed some things for people, but I learned a lot myself today. But we do have some very good questions that have come in. So
all right,
I'll start with some of those. The first one is, I've noticed that my MCV and MCH can fluctuate up at times. Can any of our medications cause this?
Yes, absolutely. So when we start looking at MCV, a lot of medication such as azathioprine, methotrexate, can affect the blood cells itself. And it depends if it is low. If it's low MCV, we look for like iron deficiency anemia. But if it's a high MCV, we look for medication, we look for vitamin B12 deficiency as well. So
Okay. And the next person says, I know you talked about PR3 quite a bit, but is the PR3 test a good indicator of inflammation and vasculitis?
So PR3 is part of the ANCA test, and it is used mainly for the diagnosis, upon diagnosis. Some centers follow the PR3 levels and the ANCA level to reflect if there is any flare or not. Most centers don't, because when they found out from research that it doesn't correlate very well with disease flare. So a positive PR3 is part of the ANCA that mainly we use it to make a diagnosis, not to follow up.
Okay, that makes sense. And this is a similar one, sort of different topic, but what if p-ANCA and c-ANCA are negative, but MPO is positive? What does that indicate?
That's a tricky one. So when I see that, and if I don't have any other symptoms of vasculitis, I'm gonna watch that because it's not that typical. There are so many kits outside, that commercial kits that can pick up a very little titer of an MPO or a PR3. I will be more reassured if I have a positive c-ANCA or a p-ANCA, but you have to take that test into the context of what's going on. Is there typical symptoms and signs of vasculitis? If there is, then I have to respect that. If there is no symptoms, then I have to watch that.
Okay, thank you. And we have a couple of questions. I think this one, it says, should both a routine UA and a comprehensive metabolic panel always be performed, or will the latter suffice? I've never had the former. UA, is that urinary analysis?
Mm-hmm.
Okay.
So in patients who have vasculitis that affects the kidneys, I'm talking mainly about ANCA Associated Vasculitis, Cryoglobulinemic vasculitis, IgA nephropathy. We didn't talk much about anti-GBM, but all these affect the kidney. So any vasculitis that affects the kidney, you really need to have a urine analysis. And as I said, urine analysis and catching up blood and protein in the urine could be the first sign, the early sign for a flare, before your creatinine goes up, which is a good catch.
Right. And related to that, there was another question. I'm just going to paraphrase it a little bit, is that I know that I have MPA, and I go every 3 months, and I give a urine sample every 3 months, and they look for those things. But the question came up, how often should you have that done?
So the first few years of the diagnosis, I really want my patient to have monthly blood tests. But this is a urine test. But then, when things get better, you cannot space it out. But so many factors goes into here. If my patient is on medication and they're doing great, I'll start spacing out the frequency of the blood test. But let's say they are off medication and they want to go on drug holiday and they're doing great. I really want to do blood tests every month and a urine test every month, because I want to make sure if I can catch something before, a real flare comes up. So it depends.
And how about when they're in remission or their disease is quiet?
Yeah, again, so when disease is quiet and then you are on medication, you're gonna start spacing out. I would say don't go beyond every 3 months.
Mm-hmm.
Well, I tell my patients I'm gonna put the standing order every month.
Yeah.
And if you are feeling well and their disease in remission and you don't feel, you're doing great, it's okay to, go every 2 months or 3 months. But the order is there every month. If you feel not good, just go do it.
Right. Well, that makes sense. And I have to add, I'm in remission off treatment and have been for a long time. And that's why. But still, I go every 3 months. So another question about that, why would 2 tests for urine, protein, blood, reflexive, microscopic show normal results, but a clean catch show abnormal results for the same urine sample? And why would urine and protein numbers fluctuate throughout the course of treatment?
So the protein fluctuates throughout the course of the treatment because when you have so much inflammation at the beginning, the kidney starts spilling protein, which is not normal. So when the kidneys heal, the amount of protein that spills gets better and your number should get better. But some patients, the protein don't get better, and that's why they have to take another medication to protect their kidneys. The other question about the difference of urine analysis between different labs or so sometimes even the collection, when you collect the urine, there's so many variables. Some people clean, some people don't clean, although it's not a urine test is not for a culture, but I urge you to clean so that you can get rid of so many other debris and white cells and things that it's easier to interpret the results. And sometimes a little bit of blood around the area may be normal, and especially in women who have some kind of dryness, and they can have a little bit of blood in the urine. So it varies from one day to another. But persistent blood, it is something that we have to look for and take it seriously.
Okay. And of course, talking with your provider is going to get you the best answers.
Absolutely.
And how are blood tests affected or reflected by Actemra, specifically CRP?
That's a great question. I didn't talk about that. So Actemra does decrease the interleukin-6. And the interleukin-6, it's the one behind the CRP and the acute phase reactant. So your Actemra, when you are on Actemra, your CRP and synthesis is going to be normal, even though if you have inflammation. So this is something that we struggle with, especially with our patients who have giant cell arteritis, that it's not going to be a very good effective measures of the CRP and the sedimentation rate, and we go by clinical symptoms as well.
Okay, great, thank you. And the next one is, I'm on Rituxan and my ANCA is negative. Is that because I'm on treatment?
ANCA usually goes negative after treatment, yes. And again, I talked a little bit about whether we should measure ANCA as a surrogate marker of disease activities. And most of the time is not really an accurate marker, whether there is active disease or not. But most of the time, the first year, the ANCA goes back negative after treatment.
Okay, understood. And this one says, how do I read B cell count in lab results? My doctor asked for this before my next Rituximab infusion.
So I did not touch upon that. So we used to look at, so Rituximab is an anti-CD20 medication, meaning that it affects all the markers, that all the cells that carries the CD20, mainly the white blood cells, and it blocks them. And so this is what we call when we say B cell depletion, meaning they look for the CD20 cells in the labs, and then we look if there are. This is a specific test. It's not a CBC, or it doesn't come up on a CBC. It's a specific test. But as we learn more and more about vasculitis, we do understand that some people flare even though their B cells is low. So, in our center, we don't monitor that, but this is a specific test that has to be ordered. Doesn't come up on a CBC.
Okay, thank you. That explains that for them. And what does it mean when your CRT is negative?
CRP?
See, it says CRT like Tom.
CRT. I'm not sure what's the CRT.
Okay, it could be a typo or it could be just something that we need to cover in a
Yeah.
future webinar. Let's move on to the next one. Regarding eosinophils, is absolute or percentage better for reporting?
I would say both. I would go more with the absolute, better, just give you the real number. And it's always important to look, and this is mainly in folks who have GPA, compared to the baseline, but sometimes it will never go back to normal 100%. So when you have a high dose, glucocorticoid is high, but then, when we look at the eosinophils count in monitoring patients with EGPA, and it goes up a little bit, and our patient get concerned, but then we understand that this fluctuate up and down. So unless it's really, really high again, it shouldn't cause a lot of stress.
Okay, thank you. Let's see. My monocyte percent is always high and my lymphocyte percent is always low. Is that from Rituxan?
Yes, that's from Rituxan. Rituxan changed a lot of the what we call differential white cells. It changes a lot.
Okay, and who knows if I'll say this correctly, is the myeloperoxidase AB test an indicator of MPA vasculitis?
Myeloperoxidase is MPO.
MPA.
Yeah, which can be positive in patients we have MPA. Yes.
Okay, and a question that came up earlier was, can COVID affect your inflammation rate on these tests?
Absolutely. Any infection increase the inflammatory markers. So that's why when we monitor, we get all these labs every day, and we were monitor all these labs, and then saturate CRP up. The first thing that comes in mind to me is infection, and now it's the flu, the COVID, all these. Yes, it increased that.
Okay,
recent surgery, infection, trauma. That's the most common causes of increased saturate CRP beyond vasculitis.
it's good for people to know that some of these things
Yeah.
are what's causing the changes. And I will say to some of the questions that have come in, if they're not specific to today, if they're not labs, even though they're very good vasculitis questions, I'm only asking the lab questions to Dr. Haj Ali. And the Vasculitis Foundation is a great resource for the other questions. One of these questions also was, can you explain Anion Gap? I see it in all my labs, but I have no idea what it means.
Yes. So anion gap is a calculation of how much the balance between the positively and negatively charged electrolyte. So if you have, your glucose is a little bit high, or you are dehydrated, your anion gap is going to change. So it's made, and it can change with medication as well. So if you feeling dehydrated, your anion gap could be changing. If your glucose is elevated, also it can change.
Okay. Interesting question. Someone said that they don't get a copy of their results, their lab results. Should they be pursuing that with their doctor?
Absolutely, 100%. Because I have patients who they get the results before I get to them. Like we use MyChart Epic, but now with every single lab you can have a portal, and another set of eyes on the blood test will help your doctor. You own this. So I really encourage all of you to look at your blood tests as they come. And sometimes, what I tell my patients is that sometimes, so now we are in a better era that things comes electronically, but before faxes used to, come to our offices and we loses the faxes. So our patient thought that, we reviewed the results and we thought that they didn't do their labs. And there was this always get, review your results yourself and pursue that.
Okay, thank you. And here's another one. If I'm saying it correctly, albumin is also on my labs, and I don't know what that means. What is that referring to, or what does it need to be?
Sure. Remember when I talked about the acute phase reactant, I said there is something positive and something negative. During inflammation, your saturate CRP go up, but at the same time, your albumin go down. So if you are very sick, your albumin is going to go down. So be careful if your albumin is on the low side. It could be chronic inflammation. It could be sometimes malnutrition because weight loss and other things that happen during acute flare. And it may take time to go up. And we encourage people to look at the albumin as well because it's a good reflection of how well you are.
Oh, that is very interesting. Never knew that information. I'm happy to hear. I'm always happy to learn something new. I did want to say to everybody that's watching, we are going to talk to Dr. Haji Ali right afterwards and see if she's available for a future recorded session, not live session, where we ask the rest of these questions, and we can tag that onto this video recording on the Vasculitis Foundation's YouTube channel. So we will ask her that, and hopefully we can get the rest of the questions that we didn't get to today. I will ask you one more, if that's okay. You mentioned that the meds to mitigate, urine protein. What are those?
Sure. So there are medication for high blood pressure. We call them ACE inhibitors or ARB. These are medication for high blood pressure, but they're also very good in protecting the kidney and decreasing the spilling of protein. When I see protein in the blood, in the urine, although my patient is in remission and doing well, but they still have protein, I always refer them to my nephrologist, the kidney doctor, to take care of that, because you want to also protect your kidney as much as you can. So ACE inhibitors, there are your kidney doctors know that.
Okay, great. Thank you so much for taking the time to educate us today, Dr. Haji Ali. I personally learned so much. We're getting a bunch of thank yous in the chat box, so just know how important your time was to us today. And as a reminder to everybody else, today's webinar will be published on the Vasculitis Foundation's YouTube channel, and everybody will get a link telling you where to find that. And just before we finish up today, I did want to ask, as patients, did you ever wonder how you could have an impact on research yourself? One of the things, let's see if I shared the correct screen. I think I did. It's about, of course, my screen is a little bit off because we need it to be correct today. There it is. The Vasculitis Patient-Powered Network is a great way for you to do something to help with vasculitis research. As a patient, you can do this by completing the Patient-Powered Network forms that they ask you to do once every 6 months. It takes like 10 minutes. I'm a patient champion for the BPPRN, and I know that it's easy to complete the biannual forms. So since I can't tell you everything today that you need to do to know about the VPPRN, I would encourage you to learn more by visiting their website at vpprn.org. What I can tell you is that it's a global patient registry, and patient data drives research in vasculitis and provides researchers with information about you. And so your experience is key for advancing our knowledge on vasculitis. And I'd also like to thank Dr. Rula Haji Ali for sharing her time here today and answering so many questions. I'd like to thank the Vasculitis Foundation for hosting these great medical webinars, and our sponsors, Amgen, AstraZeneca, and Novartis. And thank you so much for being with us today, Dr. Haji Ali. We appreciate the information, and we got a lot of questions answered today.
Thank you so much for having me. It's my pleasure.